Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. One of the basic tenets that many of us learned early in our oncology training is that you want to give your best treatments up front. And I have sometimes been suspicious of concepts that are promulgated as a principle without much data to support them, but I'm also impressed that we are increasingly seeing evidence to really argue that this is a very wise and appropriate treatment approach, particularly for our patients with more potentially threatening cancers such as metastatic lung cancer and frankly many others as well. At the same time, I would say that the stakes are particularly high at a time like now where the Centers for Medicare and Medicaid Services has just issued a statement that it should be permissible for patients with Medicare Advantage to be put on a so-called step therapy, where they need to start on a less expensive treatment approach and fail that before pursuing the more expensive treatment, even if it's really the optimal one. And I would say that this is arguably reasonable and appropriate for patients who can potentially do just as well on a much less expensive antihypertensive or cholesterol medication, where if these don't work, the impact won't be really affected for years to decades. But in a setting like advanced cancer, where patients may decline and miss the opportunity to benefit from the best treatment, it's really a mistake and a very poor choice. There are certainly pieces of data to argue that we should be giving our best treatment up front, and doing anything less than that leads to worse consequences. Looking back about 8 years or so to the initial presentation of a European study called TORCH, we saw that this study that was led in France and done in some other areas, that randomized patients without clinical or molecular selection to either erlotinib or standard cisplatin gemcitabine chemo, and then had them switch on progression to the other treatment. This showed that the patients who started on erlotinib did significantly worse in terms of progression-free survival as well as overall survival, and this led to the trial being closed early by the Data Safety Monitoring Committee. Of course, this was a population without clinical or molecular selection, and in Europe, where the majority of these patients did not have a driver mutation, and we would now expect them to be far better served by chemotherapy. That's not surprising, but what was surprising and somewhat humbling is that even when the patients who started on erlotinib switched to cisplatin and gemcitabine, they tended to do clearly worse. In fact, the response rate was only about 10% with second-line chemotherapy, the same chemotherapy that was given first line, but in the patients who got it first line, it was about a 25% response rate. And there was also a very significant drop-off of patients who started on erlotinib, but presumably had worsening performance status and various other complications that ended up leading them to not be candidates for subsequent chemotherapy that would have helped them had they started with it. So this is years ago, but we've also seen new data come out in the last year or so, such as in patients with EGFR mutation positive lung cancer who were on a study in Japan called NEJ-009 presented at ASCO in 2018 that gave everyone EGFR TKI therapy with gefitinib. Again, this was EGFR mutation positive patients from Japan, but half the patients got gefitinib alone and half got chemotherapy with carboplatin and pemetrexed in combination with gefitinib. And this is not an approach that there has been a lot of enthusiasm for, but this led to a marked improvement in progression-free survival, which is maybe not surprising because you're giving two modalities, but it also led to a significant improvement in overall survival for the recipients of the combination of chemo with an EGFR inhibitor up front. And this difference was about 14 months, so really very striking. And this was perhaps explained by the attrition of patients. About 25% who started on gefitinib did not end up getting onto subsequent chemotherapy, and there was a worse performance status in those who progressed on gefitinib alone compared to the patients who got their chemo and EGFR TKI concurrently up front. That's interesting, and of course we've seen several studies now showing that concurrent first-line chemotherapy with immunotherapy also leads to a significant survival benefit, not just in the patients who we'd seen as early as a couple of years ago getting with non-squamous non-small cell lung cancer, getting carbo, pemetrexed, and pembrolizumab, but now also with several other regimens, adenocarcinoma, non-squamous, as well as squamous. So this is now a clear theme, and we're seeing not just an improvement in progression-free survival and response rate, but overall survival. And we're also seeing that the crossover rates, even when it's built into a trial, are typically topping out in the 40s to 50% range. This may well be because many of these patients are declining in their first few months on treatment and end up not being as strong candidates for whatever follows as they would have been had they started with that treatment approach. So it's interesting that at ASCO 2018, though we had maybe years ago hoped to move away from crude chemotherapy, in fact, where we find ourselves today is that chemotherapy added to targeted therapy and added to immunotherapy for different patients may be really the best approach for a very broad range of patients, because this is the best way that patients can at least see and get the potential benefit from these modalities while they have a sufficient performance status, organ function, marrow function, etc., before something potentially bad happens, such as significant brain metastases or whatever extensive spread may lead to a decline in their performance status. And it may well be that giving these treatment approaches that may or may not be synergistic, may be just additive and treating different clones of a cancer, giving these together may lead to a significantly longer time before resistance emerges. We have a lot more work to do on this, but I would say that this is increasingly becoming a compelling argument that we really want to front load our treatments and consider combinations, even such as chemo added to targeted therapies. We have a lot more data to collect, but I think that we should take this concept seriously and not just say that we should be ranking our single agents, but potentially doing more combinations to see whether the benefit of combinations is greater when given concurrently up front than doing these sequentially. I'd welcome everyone's thoughts, comments, questions, objections. Please add them in the comments. A lot of judgment here, so I'd welcome your ideas. Thanks very much.